Hello everyone, this is Dr. Cui. So in this video, I would like to continue the discussion of the EKG. And here's the second part. So the next step, we need to analyze the P wave. So for the P wave, we can see that the normal amplitude is around 0.05 to 0.25 millivolt voltage, and it's equal to half to two and a half small boxes, and the duration about one half and two and 75 small boxes. So you can just it's about three small boxes. So for normal duration, you can just think about 1.5 to 3 small boxes. So we can use the P wave to evaluate the atrium conditions. So if the P so actually it can give us a lot of information. If the P wave is disappeared, we may consider about the atrial fibrillation. If the P wave has a different manifestations, so we may think about MAT, and if the P wave turn to the small F wave, like a sawtooth morphology, so we may think about the atrial flutter, and also based on the different P waves combinations, we also can evaluate if the atria has enlargement or not. So, for example, here for the V1, the P wave in V1 actually has a biphasic has a biphase. So even in the normal EKG, the V1 also, the P wave in the V1 also has a biphase, and we combine it with the P wave as the lead 2 in order to evaluate the size of atrium. So for example, here, so in the normal EKG, you can see that in the V1, the P wave has a positive phase, and negative phase. Positive is ahead of the negative phase, and the positive phase is stands for the right atrium depolarization, and the negative is the left atrium, and then we combine it with the phase 2 P wave to see if it has to see if it has an enlargement. Let's say if it's a left atrial enlargement, the P wave in both leads will have a wider duration, longer than the three boxes, longer than the 12 seconds, and which is larger than the 3 small boxes. And if it's a left atrial enlargement, you can see that the negative phase will be larger than the positive phase in the V1 P wave, and in the P2 in the lead 2, the P wave is also larger in the left atrium's part. And if it's a right atrium enlargement, then the V1 P wave, the positive will be larger than the negative, and also the red atrium, the left part, also larger than the red part. So basically we combined the P wave from the V1 and lead 2 to know that if it's a left atrial enlargement or right atrial enlargement. If the both atrium enlargement, then we can see that the both positive and negative phase in the V1 P wave are similar, and also in the lead 2, the P wave also similar in the left and right part, but the durations is longer than the than 0.12 seconds. So just the durations enlarged. So that's it. And the next we want to see, we need to see evaluate the PR interval. For the PR interval, its normal range is also 0.12 to 0.20 seconds, which equal to 3 to 5 small boxes in adults, but it's a little longer in the elderly people. And for the PR interval, if it's longer, we may consider about AV block, especially for the first AV block. And if it's shorter, we may when we think about SVT, specifically the WPW syndrome, which is classically has a short PR. So that's for the PR evaluation. And next, we want to see, then the next step, we will check the QRS complex. And for the normal interval, it's also about 1.5 to 3 boxes for the QRS complex. And if it's longer than the duration, so we can actually evaluate based on the duration. So for example, in the right bundle branch block, if the QRS complex is longer than the 3 boxes, and there's a dent in the V1 and a big S in the V6. So we may consider it as a complete right bundle branch block. While if the QRS interval is normal, and also has a notch in the V1, and we may consider about its incomplete right bundle branch block, as we can see that it has a normal QRS duration. So that's for the QRS complex. And then next we will evaluate the T wave. So actually the T wave can also give us a lot of information, especially for the patient who has a different electrolyte, who has some problem on the serum electrolyte. So for example, if the patient has a hypokalemia, so we can see that the T wave will be shallow, and also the U wave, we can also see the U wave in this patient. And if the patient has hypokalemia, that will be a tall T wave, bigger than the R wave. So, and then we will check the QT interval. So the QT interval in the normal is about 9 to 11 boxes. So for the male, it's about 350 to 450 milliseconds. Well, for the female, it's about 360 to 460 milliseconds. So we use it to actually, most of the time we just use it to evaluate if the patient has a long QT syndrome or not. If the patient has a long QT, we need to be careful to check the patient medication list and all the patient genetics to see if the patient has some risk factors to cause the long QT. In case because of the long QT will, if the patient has long QT, the patient will tend to have the ventricular tachycardia and the fibrillation. So that's actually it's a less threatening condition. So if once the patient has a long QT, we really need to evaluate those risk factors in case the patient the EKG will turn to the VT or VS. So that's a QT interval, and the next is STX segment, the U wave. So actually, I have already mentioned the U wave. If the U wave is longer, bigger than the 1.5 boxes for duration, and which is considered abnormal. And for the normal ST segment, it's a flatter relative to the baseline. So here's a question: how to find the baseline? And actually, we have two standard here. So the first one we use it as a baseline as a PR interval. So if and the next one is a G point. The G point is at the end of QRS complex, and we use it to evaluate if the patient has ST elevation or depression, to see if the patient has a myocardial infarction or just ischemia. And so that's for the ST segment and baseline determination. And And then we need to, so after analyze each single leads, we need to put all of the abnormal leads together to check to have a look at the whole picture of the EKG, the patient EKG. So here I just give you an example of the STEMI, the different combination of EKG to localize the STEMI. So actually, this is why we need to put all of each leads together to check the patient condition, and then here I give you an example of this EKG. So to interpret this EKG based on all of the steps I mentioned before. So first, we need to evaluate the rhythm. So we can see that the RR rhythm, the R interval is. We can check the lead 2 here. The R interval is the same. So this is the regular rhythm. Next is heart rate. We can see that it's about over the 5 big blocks. There are more than 5 bigger boxes square in the between the R interval, which means the heart rate is lower than the 60 beats per minute. So 5 big square equal to the 60 beats per minute. So this patient definitely have a bradycardia, and the sign is a sinus bradycardia, and then we want to see we check the P view, which is normal, and the QRS complex is also normal, and the T view is normal. The PR interval is prolonged, so which means the patient has a first degree AV block, and the QT interval is also longer than the normal. The patient has a long QT, and the patient also has and also the patient has abnormal phenomena of the QRS complex. So we can see that although the QRS duration is normal, there's a notch on the V1, which means the patient has an incomplete right bundle branch block, and we can also see that the patient has a ST elevation in leads 2, 3 AVF, V2 to V5. So which means the patient may have the acute myocardial infarction in the right coronary artery and the left anterior descending arteries. So based on all of this information, here's my interpretation for this EKG. The patient has sinus bradycardia, first AV block, incomplete right bundle branch block, long QT interval, and 2 to 3 AVF, V2 to V5 ST elevation. So the patient, based on the real condition, the patient has acute MI and who has a right coronary artery and RED lesion based on the angiography result. So that's it. So that's the overall review. And remember, I mentioned the last but not least, we need to relate the EKG to the real clinic, to the real condition of the patient. Because sometimes, as I mentioned, the EKG, even if the EKG is positive, the patient may have no problem. The patient may have no symptoms. Well, even the patient, so if sometimes a patient has some clinical problem, but EKG is negative. So that's why we need to always check the patient conditions after analyze the EKG to see if the patient really have the problem, even the EKG is positive or negative. So the solution here is to combine EKG and clinical evaluation. So that's it. So I hope you will. So actually, the key point for this topic for this discussion is I want to let you know that how to approach the EKG step by step, how to read the EKG by using the about 11 steps. So then you won't miss any details. If you really want to learn more about the EKG, I strongly recommend you to read the EKG textbook to check those interpretation of the EKG, especially for different combination of different abnormal leads. So that's it. Good luck for your clinical rotation.